Good afternoon, everyone. Good afternoon. Thank you so much for a wonderful morning. We're really excited to continue our discussion with our afternoon panel, which is focused on community clinical linkages. And I'm really excited to invite my colleagues and leaders here across Los Angeles County to So I'd like to start by just introducing our esteemed panel. First, our moderator is Dr. Howard Hu, who is the Flora Thornton Chair of the Department of Population and Public Health Sciences here at the Keck School of Medicine. He's also a physician scientist and internist and preventive medicine specialist with a doctoral degree in epidemiology. He's been actively engaged in leading multi-institutional and international teams of scientists, students, and fellows. And his work has really focused on investigating the environmental, nutritional, social, psychosocial, genetic, and epigenetic determinants of chronic diseases. Next, we have Dr. Lourdes Baez-Gande-Garbernati, who is Associate Dean for Community Initiatives at Keck. She's also Associate Director for Community Outreach and Engagement at Norris Comprehensive Cancer Center, and is a Distinguished Professor of Population and Public Health Sciences here at USC. And she's an expert in cancer disparities research in diverse populations with a focus on developing culturally specific, effective cancer prevention interventions. We also have Dr. Jennifer Sway, who was the inaugural Director for Cancer Care Delivery Research and Implementation Science at Norris. And as part of this role, she's responsible for fostering research that improves patient, clinician, and organizational factors that influence cancer care delivery and facilitates uptake of evidence-based practices and research into regular use by practitioners and policymakers. We also have Dr. Narissa Nalzi, who is a health services researcher and assistant professor in the Division of Health Inequities in the Department of Population Sciences at City of Hope. And her research focuses on cancer care and outcomes in underserved populations and safety net settings. And then finally on the panel, last but not least, is Dr. Andy Lee, who is the Director for Specialty Care at Los Angeles General Medical Center, which is the largest medical center in Los Angeles County healthcare network. He completed his residency in internal medicine and fellowship in endocrinology in 2007 and remained as a full-time faculty here at Keck. And then he moved to LA County, LA General Medical Center when in 2013, as it sort of ramped up the process of implementing the Affordable Care Act. So he's really transformed specialty care from a fragmented volume-based organization into an integrated value-based system. So we're really excited to have our distinguished panel, and I'll turn it over to Dr. Hu for moderation. Thank
you. Thank you, Chinita, who is a superstar of her own. We're so very proud of having recruited her. So I just want to lead off by saying that this part of the program is all about clinical community partnerships. I just want to share with you that I've had I won't tell you my age, but I've been around the block. But one of the things that really attracted me when I was recruited here in 2020 was how deeply engaged this department and so many of the faculty are here, and the members of the Norris Comprehensive Cancer Center and other researchers, how deeply engaged they are in the diverse communities right here in Los Angeles. That's living your values. I did not see that when I was at Harvard for 18 years. I did not see that when I was at University of Michigan, where very few of our faculty were doing anything in Detroit, just 40 minutes away, one of the most challenged cities in the US. But here, we are deeply engaged. And that's something that I loved about USC and Keck. So I think this is part of the ethos of what we'll be discussing today. I'm going to ask each of the panelists first, starting off with Professor Tsui. Tell us about your role and how you interpret that role in the context of the subject today.
Thank you, Howard. I think in most of these contexts, the first thing I always say is I'm a researcher, right? And this morning, it was Dr. Gottlieb who made the great point that we need the community to lead us and tell us what they need. And I wear lots of I do multidisciplinary research. I think I'm a health services researcher by training and implementation scientist. And my focus is on cancer care delivery and disparities in cancer care access and outcomes. But really, that is all driven from the STEM as a health equity researcher first, right? It is all driven from the equity standpoint. And so the methods we use, the frameworks we talk about, the settings that we need to engage with, the multi-sectoral partnerships we've talked about this morning, that changes when every time we sort of think about what problem is at hand, right? And so we need to be nimble with that. And I think I'm a health services researcher by training, but a lot of times I rely on my health behavioral scientists, my community-based participatory research experts. And so I think most of my work rests on HPV vaccination and cervical cancer disparities. That's how many of you know me. But I think that's a vehicle to understand those underlying social determinants, the structural racism, the segregation, the disparities in the healthcare system that still persist for why a cancer that we can eliminate is still here. So I think that's sort of where I come from in terms of why I study what I study.
Lourdes.
Thank you. Well, first of all, I want to do a shout out to our COE team that is all back here. Please raise your hands so they can acknowledge you. Because it does take a village, and we couldn't do this without them. And I also, not because she's here, but I also want to acknowledge the work that Dr. Lerman has done, because my work has been facilitated by her work. One of the challenges that we've had with our COE was to integrate it more into the Cancer Center and the basic sciences. Imagine a community person trying to do this. And if it doesn't come from the leadership to make it happen, it's hard to make it happen. So thank you, Karen, for that. So it's all of us together. And I think that is the key phrase, the togetherness of it all. I know earlier they talked about bidirectionality. And we at our Community Outreach and Engagement Office do take that very, very seriously. Our Community Advisory Committee, for example, participates twice a year with the leadership of the Cancer Center, with the actual decision makers at the Cancer Center. They review the burden of disease in the community, and they also help us set those priorities for our communities. And Dr. Lerman comes to our functions. Howard has come to our functions. Jen is at our functions. Many of you have been to our functions, and we reach people anywhere from one-on-one to over 500,000 at a time. And so the key is, how do we take life-saving information to people before they need it? So somebody talked earlier about the value of the family. So we really believe that families and patient advocates are really a key and integral part of everything that we do, because it is through them that we're able to sometimes communicate with the patients more directly and be able to engage them in a series of things. One of the things that we are working really hard on, and thank you, Brian, for your presentation, it was absolutely terrific, is the engagement into clinical trials. and to really get different communities to be more and more engaged, because treatment options will be better and will be more targeted towards them. Yet we still have a long history to make up of hurts and pain. And so by us being out there as a voice of reason, a voice to trust, someone that is embedded in the community, we're out there, funerals, quinceañeros, it doesn't matter what it is, we are out there. Shootings, and we're out there. We've had, last year, we had a shooting in the Chinese community, and that same weekend, we were out there. And they came to us to tell us that they were grateful that we were out there, because in their worst hour of need, our cancer center had not abandoned them. And so that's what togetherness means. You are integral part of that community. Therefore, you want the best for that community and for those patients. And so how could we do any wrong if we're together with that thought? So thank you.
Hi, Narissa Nanzi from City of Hope. Yes, and a lot of my research, I'm a health services researcher by training, and a lot of my research focuses on disparities in cancer screening, specifically within safety net systems. And I appreciate how Dr. Gottlieb had brought up this morning about how, we can view our community health centers as the community actors as well, given the importance and interface they have with the community and sort of being the front line for cancer screening and cancer preventive services for our community members. So I appreciate that. In the context of COE, I'm the Assistant Director for our Community Outreach and Engagement, and in terms of clinical community linkages in that context, I would say that we do this in a couple of fashions, from low intensity to high intensity, from information dissemination on cancer education and screening with information on linkages to care after that. On a second level, capacity building. We have a lot of efforts focused on the Cancer Care Equity Act, which City of Hope helped to lead. And this really focuses on linking Medi-Cal beneficiaries who may not otherwise have traditional access to NCI comprehensive cancer centers and other qualifying cancer centers, providing, expanding that access to specialized cancer care with NCI CCCs and other qualifying cancer centers. And sort of really on the highest level, like service delivery, we also are supportive of our mobile cancer screening and prevention program, which is launching this spring. Very excited about that. It's a lot of effort, and led by Dr. Susan Brown, Kimberly Ashing, a lot of other members within City of Hope. But this is really all about that, right? Interfacing with the community to link them directly with care, going to where the people are, and not only that point of service and episodic care, but linking them back to a health center where they can continue to get the needed cancer screening in order to receive the best benefit from those tools. Thanks.
All right. My background's in endocrinology, diabetes, not cancer care, just in full disclosure. And the reason I'm actually speaking about cancer care is I think it goes right back to 2013 when I actually was part of LA General's, I think, executive team and really rolling out the ACA. And I think from there, I trained here in LA General way back, when I think LAC USC with, if you ever worked there was 18 floors, and you saw disparities left and right. You saw access issues. But back in 2013, there was a recognition that healthcare disparities is caused by healthcare design, right? We create the system. And the problem was patients were not really involved. And there was a recognition that, at least in California, everyone should have insurance. But how are we going to roll it out? And we had an opportunity in Los Angeles County to demonstrate how we can roll out an Affordable Care Act. And we were successful. Fortunately, the administration changed. So rather than actually being celebrated, we were really ostracized for actually demonstrating how we could actually implement a Medicaid program and everyone can have insurance. So what I'm here is, it is a healthcare design issue, right? And we have to be informed by the right patients and the right patient advocates. When you do, then patients actually receive the care that all taxpayers pay, right? So in Los Angeles County, we have actually, starting January 1st, everyone has the ability to sign up for a healthcare plan. This is the new thing, right? So every single patient, cancer patients, non-cancer patients, has a health plan, should be tied to a primary care physician, and has access and the right to affordable health care. This is a reality. But as we know, for our patients, they don't understand that these things are given to them, and they still get fragmented care. So what I'm hopefully trying to share here in this meeting is we have a lot of research, we have a lot of really knowledgeable people, a lot of advocates, but where should we place our focus to really implement some of these policies and procedure in all the clinics and healthcare systems, and more importantly, how do we advocate for the right funding to really build this in a sustainable way? So one big thing we did do for LA County was we did create a system-wide navigation program with an effort to amplify the patient's voice, right? Through a patient navigator, they do go with the patient to their neighborhood, their local ecosystems and communities, and from there, we're able to amplify their voice throughout the continuum of care. And this has been in existence now over a year and a half in implementation, and we're just seeing really great results. And again, I'm going to end with the fact that it's caused by healthcare design. And if we're better informed with how to design healthcare better, I think it's more cost effective and it's better for the patients.
So I have a set of questions that I can ask the panelists, but one of the side effects of having such an articulate panel of speakers here is that they've already addressed a lot of them. So I'm going to riff a little bit. One of the questions that I would still like to pose is this one, which relates to the fact that we're both scientists coming from these academic centers, but we're also creating these relationships with communities. And that certainly always raises the risk of the white ivory tower syndrome. So even if you can develop these collaborations, how do you get over sort of the barrier that can exist? Some of even psychological, afraid to ask questions or afraid to test the power of authority in order to truly participate in the activities. Can any of you address some of that?
I could start by addressing a little bit of it. One of the things that we do in our community is really how embedded we are in that community already, where that trust has already been built and where we've set up a relationship of co-learning. And so that begins to provide a foundation that when you come in with a project, when you come in with research, when you come in with specific agenda, of course, their agenda may or may not be the same as yours, and that we need to recognize it. But then trying to find what is the common ground, what are the areas that you can provide that they may need, and what can they provide to you that will enhance what you're doing. We tend to work on a deficit model a lot of times, especially to get funded, and yet our communities have tremendous strengths. And it is based on those strengths and those resources that you can bring to the table, both that you deliver and that they can deliver to you, that you can really enhance the programs. And yes, there will be competing demands, and there will be the rigor of the academic setting that sometimes clashes with exactly what you're trying to do. So just yesterday, we had a conversation in one of our programs with the CoGenes program, because we're about to launch an RCT, and we're trying to figure out what is the reality of implementing that RCT in that community, and how do they really operate? And so we made all these changes, right, Bianca? She was there, just to ensure, and Janet, that we are really in tune with those communities and really in tune with the people who are going to receive, whatever information or the actual clinical trial.
I'll add to that. Agree on the alignment of missions and trying to understand your community partner. I would also say a basic thing is to give before you ask. And this should be happening years. Giving your time, giving the resources, giving your grant writing abilities to help them acquire community grants. Funding announcement recently came out, and the first question I'll ask is, how much of this can I give to my community partner? It should be given the maximum amount to our community partners. So I would say that relationship and trust and foundation needs to be built as well. Giving before you ask.
Such a very complex question. I think from what we learned from the pandemic is we have very little understanding of community trust. We, during the pandemic, our hospital actually tried to engage community-based organizations and also churches to really try to change the perception of what vaccination meant, and it was very difficult. And many different health plans also have been exploring different ways to really leverage community voices to be able to translate the information. But I can say that what we had thought were really great advocates for the community may not actually be true advocates. So these are just the realities of when we really needed to communicate a life-threatening. We found that out firsthand. In terms of partnership, I think there's a different set of partnership when you're with a community and actually having them collaborate in having data versus informing them about something that they want to push. And what we see a lot is a lot of communities want to reaffirm their understanding rather than having a better understanding of their community. So it's very important when you have a collaboration to know where you're going to go, right? Because a lot of them are sustained by funding, right? So if you come out with a research that says maybe putting a neighborhood grocery store won't improve obesity outcomes because it may not be aligned with their mission. So I think the type of partnership, where their roadmap in terms of sustaining their community, you have to be very sensitive to that as a researcher. I think that's very important. That's something that we've learned. But I would say probably the biggest ally as a healthcare center is really our health plans and also the FQHCs, the community health centers, who really have already an independent channel in knowing that they really want to support the rigors of research. And if you find better ways to have better partners with them, I think you'll have more of a sustained, I would say, research, either RCT trial with the community, because the community, in terms of advocates, they change quite a bit with also the political tides. And this is all based on funding, and we find that a lot. So at LA General, certain times we have connections with a certain group in Boyle Heights, right? Very strong. And then sometimes the political climate change and that relationship change. You might be in the midst of a 5-year RCT and things change, right? So I think understanding the nature of your relationship with something that will test time over 5 to 10 years is going to be very important. So just some insights.
Jennifer, you want to take a crack?
I think, what we know from this panel is we are so passionate about this topic. So I love that. Very little to add. I would just say one thing to tie an additional point that was made this morning is about context, right? I think building strong clinic community partnerships and strong relationships really requires us as researchers or the health system to understand the context of who we're working with, right? And a lot of times that context differs even within sites within an FQHC system, right? So we missed Jack Chang this morning from Chinatown Service Center. He's one of our partners on a HRSA initiative. And our team, some of my team are over there, Belle and Emily, have gone in and really tried to learn how is their Chinatown site different from their Alhambra site and their San Gabriel Valley sites, right? We have different communities, even within the Chinese population. There was that point earlier about heterogeneity within Hispanic Latino communities, right? And geographic barriers. I think the more we understand how we need to adapt our research to context and what the needs of each partner is, the better we can address all of these things that we've already just mentioned.
Thank you. Thank you. All right, here's the next question to serve up. What areas of the cancer care continuum do you think would benefit most from clinical community collaborations? Who wants to tackle that first?
I'm gonna take my experience, at least with our cancer navigation program, some of the data that we're showing, not just at LA General, but throughout Harbor UCLA and also all of you. What we're finding is that newly diagnosed patients, it's the first time they intersect with the healthcare system. So everything we measured and we talked about, whether it be through the PREPARE or social determinants that probably Laura Gottlieb, but I wish I was here, she's a great friend, that she's really worked on. That everything that we know that impedes care is realized at that moment when someone has cancer, right? They have to know their health plans. They have to know whether or not they have family support. many of our Medicaid patients say they take maybe months to even reconcile the fact that they have cancer. And I do think that from our standpoint of this population here locally at LA General is that there's cultural barriers, language barriers. So all those social determinants really comes ahead. And I feel that for a healthcare system, it's very difficult for us to address that alone, that we need the community partners, we need the communities, we need that trust, because the patients will recede back to their communities and potentially get other information regarding how to treat cancers and things, and that delays the level of care. So I do think starting with public service, education in local communities, and really explaining at the point of after screening, when you do have a diagnosis of cancer, how best to intersect the healthcare system, and as a Californian, what you're afforded to. You have insurance. You have assignment to a primary care physician. It is your right to be able to ask for the type of specialty services. This has been the advocacy that we've been doing at LA General and for much of the Cancer Navigation Group, is really to explain to the patients or the person that they've been afforded some health plans that can actually serve much of what they were actually receiving from the community that they didn't even realize they can leverage. So I would personally start with at the point of diagnosis, education, and also intersection with the healthcare system.
Maybe a little biased, but I'm going to say prevention and screening. I think we've seen in many of the models that were presented earlier this morning how it starts with the upstream prevention. So really being able to understand the social context at that point of time can really not impact only your cancer journey, but for other chronic conditions as well.
Well, since we're sort of going along the continuum, I'll take it up like once you have cancer. So we've had an experience fairly recently with our Moonshot program, and Charité and others are here from that program. And with that program, what we found that our community advisory board members were all people who had cancer. Some were terminally ill. However, they all wanted to contribute because they knew that what they could give could be something that could give back, not to save them, but to save others. And so to me, one of the key things is how we get people to participate in life-saving trials that are going to make such a difference, even if not for them, but for people in the future. And so being able at any phase within that continuum from prevention to tertiary care, to be able to include the voices of these patients and these individuals in that continuum of care is really critical. And then for them to have a say in what we're doing, whether it's in the care system, what are the barriers they face. Charité is here, and we always talk about the difference of our populations with LA General and the Norris population, for example. Talk about social determinants of health. You could see just a tremendous gap just right there. So by participating in these trials and really engaging, but we can't get all of them to come. It's hard for us to get African Americans to come here, for example. We're hoping Shanita will help us change that. But, it really is a struggle because we're in a more, Latino area. And so we're really successful with those groups. We're now really envisioning going out to do further outreach with the Asian Pacific Islander community with Dr. Sway and her wonderful team here. And so really the engagement of patients and their families at every point throughout that continuum, and the development of advocacy, because we also try to really work hard on that advocacy part that you mentioned earlier today, so that they in turn can become the best advocates for their own health and what is needed.
Being last is so easy on this panel. I think the only remaining point is just also not letting the healthcare providers off the hook. I'm sorry, but the clinician to clinician, the clinic to clinic handoffs, the transitions between each of the phases of care we just talked about. I think just learning more even in the science of what is team-based care and what does that mean for a patient. figuring out how we all work together. We said that earlier this morning. How do we really work together across health systems between FQHCs and hospitals, I think is really one of our next agenda items to figure out in the afternoon. Right, Shanita? Yes.
I wonder if just follow up a question on that. I mean, I interpret the continuum of care from the very beginning and prevention, I guess, all the way to the end. Are there thoughts about end-of-life care? I mean, cancer is a horrible disease. We have made so many advances, but still there's that last part. Are there disparities there, and are there ways that the community can work with us to ease the burden at the end?
So yeah, I think palliative care when we look at the full cycle of care, obviously we talk about actually getting survivorship, but when we get to palliative care, it's a very difficult field. And we do have a palliative care. If you guys work with Karen Vinzel, she's our lead for palliative care. And it is a difficult field only because I think when you look at any disease process, so let me just put the business hat on, right? So I support prevention. I love that. But in general, when you're looking at a healthcare system, people talk about high-cost care, right? It's a high cost that you really improve to pay for everything upstream. This is how things work. And palliative care is just not having it. It's inhumane, but it's very hard to really model what it does in an institution. So for me, a lot of times when we did invest in palliative care, it was really driven by advocates to patients to say that this is actually tremendously necessary. But to really convince the healthcare system that the ROI of having palliative care it's very difficult to negotiate unless you have very big advocates in the healthcare system that understands the nature of the continuum of care. So one thing is it's very expensive, and also the individuals that lead it, they're very unique. Okay, not everyone can do palliative care. When people do intersect with that type of discipline, quite a bit of turnover. And so I do think it's a very difficult field in the entire cycle of care, and it's driven by people who are extremely mission driven. So that's my experience in terms of that field.
Okay, it's harder not to go last. I would just say, I think here at USC, we have Dr. Steve Grossman and others who are partnering with multiple other cancer centers to look at this, because it does require leadership support and system change. It still goes back to my context question, right? What does palliative care mean for the specific communities we're working with? And how do we need to intersect community stigma and beliefs and acceptability with that side of it? And so really being attuned to both the business model, the design issues, as well as the communities we're working with, and how do we need to be adaptive to that is
Well, having had both of my parents pass away, and at the end of their life, both were in palliative care, I can tell you that the cultural struggles with that were not easy. And I am someone embedded, in cancer care and for a long time in this business. And to tell my family members what they interpreted, what you're giving up, it's really difficult. And yet to be able to navigate families through that process and to understand, no, they can't give them, another IV because that's not part of a care. But you're gonna let them die? These are the kinds of questions at the end of life, having that palliative care there where they tell you, sometimes you gotta pull the plug. Goodness gracious, what we're talking about here is profound to our psyche and to who we are and to who we are as people and as communities and as providers. And so not all communities are alike, not all families are alike, and being able to talk ahead of time about these issues with also dealing with the fact that you're not wishing it upon them, which is another kind of thing that you get back. but really understanding what is happening within that unique family. They could be Latino, they could be Asian, they could be African American, they could be from any walk of life. When you get to that moment, it's like everything stops for you. And it doesn't matter what walk of life you come, what socioeconomic status you come from, you are there helping someone pass that transition. And having a palliative care team that is culturally really in tune with you and is sensitive to all of that that's happening is really critical. So I hope that our patient navigators will encompass that entire spectrum of that, so that our communities can go from birth to death in that transition in the most mild and gentle of ways.
Okay, that was a tough one. Let's go back to a softball. One of the ways, of course, that we are able to work with communities is by working with representatives of the community, and the typical vehicle is a community advisory board. I wonder if you could share some experiences or thoughts about how best to work with community advisory boards, or even construct them, how they operate, how do they best represent all these different heterogeneous segments of the community. If you could share some of those experiences.
You want me to start? Okay. Okay, by vote, I'm starting. Okay. So, you know, we really believe in the power of community advisory boards. I think they make a huge difference. The one that we have been running at our Cancer Center is composed of 13 members, all from the diverse communities of Los Angeles, including American Indian populations that are represented there. And we meet on a sort of twice a year, very, very formally, but we're meeting with them all along, almost on a monthly basis, sometimes weekly basis, on issues that come up or that we need to work with them. Having those boards, depending on what aspect you're particularly interested in, are really critical to provide feedback, to know that you're doing the right thing at the right time, that you really have the pulse of the community, and that you're getting to where you want to be. What is your outcome? Where is it that you want to go? And in what way can they influence the process? Sometimes that takes us to broader boards, kind of like I'm working now with Howard on setting up a community advisory board for our Department of Public Health. So that board is going to be composed, including of community leaders that are incredible decision makers and that can advise us. I mean, during the pandemic, we had to shift on a dime. Who the heck knew what we were doing at that moment? You know, all of us had to completely change course of everything that we did. So these community advisors are going to be there really having the pulse of what's happening in health, not just, you know, locally, but also at a national level, so that they can advise us and we can be ready for the next threat, for the next pandemic, or just because we had a measles outbreak out here, what are we going to do about it and how are we going to do that? So they help to predict, they help to advise us before things happen of how we can better prepare for it. Getting an advisory board together takes time. It takes time to make the right decision of who's on your board. You don't just want people that will rubber stamp what you're saying. No, you want the naysayers there too. You want them to challenge you, right? Karen, she gets challenged all the time by Freddie. You know, you all know Freddie, right? You know, I mean, it's like that. You need a board that's not going to just rubber stamp because you think that was important to do and say. They will really look out for that community. And yes, you only pay them $1,000, unfortunately, you know, for their service, but their services are invaluable. And hopefully one day we can pay them a whole lot more, and that NIH will allow us also to do that.
So many great comments. I agree with all of that. And we also take a very multi-ethnic, multi-sectoral representation within our community advisory board as well, and really appreciate their service. Again, we do meet kind of quarterly, but also have frequent communications in between too. That's certainly not sufficient just to do quarterly. And really engage them with our researchers as well. How can we connect our researchers with members of our community advisory board to advance their initiatives? That's really important. And I agree completely. You want the ones who will hold you accountable, who are the naysayers, who will be blunt, and who have that trust to be able to communicate their opinions to you and really be the eyes and the ears on the ground. So, yeah.
I agree with everything that's been said. I can just tell you a few nuggets. Well, we have a patient family advisory council at LA General, and there's also one at the system level in DHS. It's quite difficult to groom someone through the process because you don't want just someone participating, right? You want someone to actually have the commitment to attend regular meetings, but more importantly, to be able to speak out, right? If they're agreeing with everything, there's really no change. And I would say personally, probably the biggest thing that's been a big gain for us is someone who would actually, first of all, voice the community and really speak out if something's not working, but at the same time will really vouch for what your intentions are. Not necessarily sometimes you're going to get into conflicts when you do anything in healthcare. Not everyone's going to agree. But when you have a patient advisory council or a collaborative that will say, maybe this researcher or this grant or maybe this med center, maybe they did something that was inconsistent with the community, but they had the right heart, the right intention, and we support that. And those are the type of partners that will be with you through the entire process. And I would say our partnership is better because of our CEO. We have a lot of people that we hired that actually are from the community that's at the hospital. So people feel like they have ownership in either research or any of the hospitals. But it's really hard to find those individuals. But when you do, it goes a long way because they're with you through the entire co-design, and also they're your biggest advocates in the community. Right.
If I could just add one last thing. Don't shy away because they don't speak the language English. I mean, we now have boards where we actually have simultaneous interpretation to make sure that there is the proper representation of all groups in the diversity of Los Angeles.
Jennifer, did you want to make something?
No, when you're lucky enough to work with Dr. Lourdes Paisconde Garbinati, there's nothing else to add.
She is the Associate Dean for Community Engagement for the Keck School of Medicine. Okay, well, we have about 3 minutes left. I just want to open it up and see if anybody would like to make some final comments about this whole subject. Experiences, things to learn.
I don't know if this is on. Okay. I just have to say, since the pandemic, and actually one of the biggest things that we're addressing is digital inclusion and equity. And I have to say, it's really shocking how sophisticated our communities can be once they're informed. And when they co-design and they actually push healthcare in a particular direction, it can really shock the system in a good way. And I've had the pleasure of really supporting some of these initiatives from the patients. And I think that type of partnership should drive research, because I think at the end, some of these things it may not reach a balance sheet, but at the end, it's each one of us who might intersect with the healthcare system, we understand the value. So I just want to make a statement in terms of how important it is to have that community linkage, but more importantly, having that trust and that advocacy to be able to guide your research. So.
And I'll echo the point from this morning related to the collaboration. I know that's a conversation that's continued throughout the day. A lot of us have been in different parts of LA for long periods of time, and if we could just combine forces in order to work together on common initiatives, I think it'll be a beautiful thing.
And I just want to leave you with a thought about investing in these communities, investing in these partnerships. I think that, for example, the partnerships that Dr. Sway and I have developed with our FQHCs, with us with Altamed and Dr. Sway with the Chinese Service Center, are just invaluable to us. We each received a grant that helped us to establish those partnerships, and the grants go widely to them. more than to us here. And so, really sharing those resources with them and establishing that relationship with those clinic partners is really essential. They will help you in every single aspect of delivery of care, of prevention, and everything from that list. One of the things we're working on right now that I want to mention, and Shanita stepped out, but she's been spearheading that. Oh, okay. It's our USC Connects. So one of the things that we're trying to do is to work with the FQHCs to try to see how we can bring patients in a much easier way, in a much faster way into the system. Whichever of the different systems we work in, they will qualify for and be able to do that. But it is so difficult to get to that point. And yet, we're together with our FQHCs and with the partnerships and the people from within the university, the healthcare system, the cancer center, to do this. And so all of us, like I started together, we feel that we can make a difference and that our patients can achieve the care. Sharon spoke earlier about the numbers of people. She actually has 1,200 people on the list waiting to get colonoscopies and be seen. And so how do we accelerate that process? Each one of those people is a potential life saved. And so that's what we need to take with us. We have to invest in those relationships to make sure that we continue to save lives.
30 seconds.
30 seconds. Okay, so in a nutshell, I would say when you are inspired by leaders like Karen and Lourdes and Shanita, you really learn that what you need to do and what we can probably do in this room is to go big, right? We have tools, we have evidence base. We know when we need to adapt. We know when we need to be nimble and when we need to work in partnerships. We just need to go big. We need to bring the payers along, the systems along, and all of the communities that we've already established many of these relationships with to go big. And going big is not easy, but I think the take-home message is we have to think bigger in order to solve many of these deep-rooted problems around social determinants and social risks that we've been talking about for so long.
Please thank our panelists for a great session. And now, back to Shanita.
Well, thank you again. Thank you, Howard. I'm really excited to introduce our next speaker. As you've heard, we're really grateful for the support from Genentech. And one of the things that I have been so impressed by is their willingness to support efforts to bring all of us together in this room. And this is, I think, is also due to the work of our next speaker, Meghan McKenzie, who works in patient inclusion and health equity in Genentech's Chief Diversity Office. And in her role, she works to develop strategies to drive greater inclusion of racially and ethnically diverse representation of patient populations in clinical research and to enhance health equity. And so one of the things I think is really important is, as we've had our conversations today, Meghan has really been at the forefront for Genentech in gaining patient, clinician, and community insights as programs are developed earlier, and because that's integral to understanding what's important to patients and improving access to medicines and treatments for all patients. So join me in welcoming Meghan to the podium.
I heard it, go bold. I am so excited about this workshop. I can't tell you, I'm hearing people at the breaks. You don't want to stop. You've already got ideas. I heard navigators. I heard RNs talk about chief of staffs needing to speak up and getting the C-suite level involved in diversity and inclusion, inclusive research, and health equity. And it's just my honor to be here today. I'm so excited to hear from everyone. We have a lot of partners who are helping us with health equity. I think the main word I'm hearing is communities, and that you can't do it from the outside. You have to bring community in. So my hope is that we share with you how we're working with communities. Tell us what you like. Tell us where we should double down. Tell us what we should do differently. We're here to listen, and this is not turnkey. This is maintain the momentum, long-term, how do we do it together? And I love folks who've said this is not a competitive space. We have a long road to have equity and access and information and health literacy. So just my honor to speak today. You're gonna hear me go fast. I'm gonna slow down and tell you a few stories. I am gonna share with you what Genentech is trying to do to focus on cancer disparity and ending them, bringing that to action by addressing social drivers of health. So I'll talk just briefly about our advancing inclusive research and health equity commitments, how we are thinking regionally where disparities are greatest and focusing on health fairs, fiesta fairs, cancer screenings with referrals. And then I definitely want to have a ringer around UCSF. I know you're in the room, the resilience effect and how you changed policy based on the work you're doing, and then what social drivers of health we are collecting, including optional self-reported sexual orientation, gender identity, and education and income. You know, if you have a high school education, your outcomes are longer. Did you know if a man is married, and I'll say and has a partner, they will live longer? My husband disagrees, but it's true. And now, I know I have more questions about that, right? The social context, the structure, the support we have. You've just amazing speakers, by the way. A big hand for everybody who's part of this. So at Genentech, we believe diversity and inclusion is everybody's business. I'm very happy to report our Chief Diversity Office, where I've been working the last 4 years, reports directly to the CEO, who embraces fostering belonging for our people, advancing inclusive research and health equity for our patients, and transforming society for our communities. And every single one, 100% of our 150 officers have an action in 1, 2, or 3, all of these pillars. And it's transparent, we publish it, and we measure it, and we monitor it. And in advancing inclusive research health equity, all molecule teams are asked to develop inclusive research action plans. And I know the FDA, this should get an applause, by the way, I know the FDA is mandating diversity plans in 2025. We have done over 20 in 2023. We have to learn together how to do this well and bring representation into clinical trials. And then establish in biosample diversity, I heard that today too. Over 90 to 95% of our biosamples are from patients of European ancestry. Please look up All of Us if you don't know it. For not only will they test your biomarkers for free, they will provide genetic counseling if there's actionable genetic markers found. So just knowing those partners, right? Very important. Very multifaceted. I am very thankful to have partners in the room a heck of a lot smarter than me that understand how to pull this through in communities I'm not familiar with. We all have unconscious bias. How do we lean in and talk about that for the benefit of our patients? We have systemic racism in healthcare. We have systemic racism in geographies. How are we moving to eradicate that and having those hard discussions? So I love the talk earlier about unfortunately, what we're seeing with lung cancer rates, but evidence generation. I'm with you on the AI. My boss is over there. He wants AI today. But I am worried about the people that aren't part of the data. I'm worried about, I don't know if everybody saw, raise your hand. I want you to be active here. Kids on the curb outside of McDonald's during COVID, accessing the internet from McDonald's to get to education. Kids at home that don't have internet. What about the folks who, and we're talking about it today, they don't have food on the table. They're not walking into the door to get their mammogram screen or go to even just a PCP. They're not in our EHRs. How are we reaching those patients? Health literacy, talked a lot about translations, making sure they're part of your budgets for your investigator-sponsored trials, but translating to language. And then those folks who do have the internet, who believe what they see on the internet, and they're scared because we're gravitated to what the fear is, and we stay away from it. So we don't gravitate to Western medicine. By the way, 8%, single digit, our medications we're creating, working very hard to create, only reach about 8% of patients worldwide. So we have a lot of work to do. Policy, I'll give a couple of policy examples, strategic funding. My hope is after this workshop, you're gonna think of something so big and bold, you're gonna submit it to our Health Equity Innovation Fund and work with them to seed better work. And then access and partnerships. Sorry, I flipped too fast, but partnerships, Congressional Black Caucus, Congressional Hispanic Caucus. How are we partnering with folks who really understand their communities? National Minority Equality Forum. We have sites in our Advanced Inclusive Research Site Alliance who are doing very well enrolling communities of color. How do we understand their best practices and bring them in and share them with all of our sites? I'm not going to go through this slide because you're very well equipped, but I had to look this up yesterday, I'll admit. 103-year life expectancy in Mono County. Anybody know where that is? I think we want to retire there. It's about 5 hours east near Mammoth Lakes. If you're in Northwest California, your average life expectancy is about 75. That is huge, and we unfortunately see this in every state. So, how are we better reaching communities? And we know 80% of outcomes are due to social drivers, and we can no longer just provide meds. We need to provide end-to-end care, how to help people with food insecurity, housing insecurity. So these examples will go through that. You're here today because I have a colleague who's a heck of a lot smarter than me who lifted last year a program called the Regional Health Equity Symposium, because we knew that we had to tackle problems locally, like what the burdens of the patients and the barriers of the patients here don't look the same as they might in Bronx, New York, or in rural Kentucky. So bringing stakeholders like you who really deeply care about access, and it's patients, physicians, nurses, pharmacists, policymakers, so you can take that forward and actually have access for your patients. Over 52 programs across 26 states. It's continuing again. She's accepting proposals, so think up some great ideas, and please, we're all ears. I'll do this quickly, but here's a few examples of where what we hope is it doesn't stop in the room, right? When you leave the room, something big grows. So an example is from Cleveland Clinic, who are sharing best practices around how they're reaching their ethnic minority populations and how they're not reaching them. And through this work, it was a day of education, they were able to get significant funding from their own institution to double down on screenings, follow-up, and diagnostics. They got that information and they were able to move it forward. West Cancer Center in Tennessee believed really strongly. I heard in the room, this concern that you might, a community hospital would be concerned they might lose a patient if they refer them to a specialty center. So how are we building trust in the community so that HCPs know their patients will come back? In this case, they were focusing on ensuring they were reaching their Black communities, and they developed a C-Color workshop that was around leaning into unconscious bias. And I do have a story there quickly. My interns teach me a lot. I had an intern from last year who showed me an Instagram of a woman who was an emergency ambulance driver, and she talked about this Black woman who was having a heart attack in the ambulance who said, please, please, braid my hair, because if I show up in the emergency room, I'll be treated like I'm crazy. And then the litany of messages from women saying, from Black women, I've got to dress up before going to the emergency room, otherwise I'm not treated with respect. And I have even harsher stories, if we have time, from interviews we've done with our Black and Latino patients of how they were ignored when they wanted workups. And I'll go into that, but I don't think people realize, unless you've lived it, how rough it can be for our Black and Latino patients. So we're trying to get patient interviews in so that we can help change behavior and help people lean in to bias discussions so we can change that. Another LGBTQ mental health, Washington Health Alliance has over 150 organizations, and they wanted to understand how to help their LGBTQ community. Had a showing of, I think it was Shades of, do you remember? A film that had 50 individuals talking about living as LGBTQ in their environment and not feeling like they belonged. And our transgender individuals are dying much earlier than our cisgender individuals, and they're scared to come out to our physicians and not being treated for things that have them at increased risk for 7 different cancer types for respiratory disease because of social drivers of health. But they now are leaning into more local events. So I'll go fairly quickly, but I heard fairs, the importance of health fairs. We had some folks in Texas who felt it was really important that their Latino community was served in screening, and they trustworthy community partners. They partnered with the Latino Promotores organization, who brought 500 individuals into Fiesta Fair. It's an amazing celebration with music. And the hard part is that some families were waiting outside the door at 2 a.m. to come in for these healthcare screenings. It's such a dire need. And partnering with Prevent Blindness of Texas for vision screenings. And of course, our Genentech colleagues were there to talk about health screenings and the Patient Foundation. I mean, AstraZeneca's here. I'm really happy to see other pharma here. We have patient foundations that provide medications for free for families who are who are lower socioeconomic status. So having more of these fairs. Also, another example, so I'm hoping you can get some ideas of how to partner with some of your local organizations, your Latino or your Black foundations, and how you can bring in more education, access, and screening. The National Minority Equality Forum specifically wants to help underserved communities for health. And they knew in Flint, Michigan, because of the lead in the water, there were increased risk of cancer. And we have a lot of folks that live in every state, and they brought this forward to us and funded health screenings and referrals in this community. It's kind of just really needing to work with folks who are already in the community, not come in and tell people what to do like we might know what to do, right? We don't, unless you live in Flint, Michigan, you don't know. And then this one, I'll pause for just a minute because the community created this for the community, and we talked about mammogram screening and women who were scared to get diagnosed because they were uninsured and they wouldn't get the help they need, so they just don't go. And these were survivors. These were folks who had their mom, their sister, their daughter pass away from breast cancer, and they wrote letters to the women who passed away about how much they loved them and how it was so important to get mammography screening. And this was in New York, and it was launched during Breast Cancer Awareness Month, and now we have other organizations that are starting to do similar things, and for Latino women as well. And you can find this, you can go on the ACS website and find these campaigns. ACS, you know, it's amazing. They're also realizing it's just not national. You have to think locally. So us and other pharma are partnering with them to pick geographies where the disparity is highest from cancer, and to go there to offer screenings, and then trying to bring in policymakers to make change. So this is new, so we'll be seeing where they pick. ACS will pick those locations, and I would be interested in how we double down in those communities in other ways. And then I'm going to play this clip really for a second because I want it inspires me. It's how just
research has shown.
Let's just listen. This is Dr. Nadine Burke-Harris, who used to be a UCSF physician, went to Sacramento, and it's about how some seed money in 2016 grew to change policy for families. So yeah, if you'll just play that for 1 minute, please.
There is no way that I can see that glow that a child has and not respect the immense amount of resiliency that is innate in children.
I really try to encourage Amari to follow his dreams. He talks often about wanting to be an engineer. But there's a lot of challenges in living in this community. When there are shootings, his heart is racing, he's very scared, and he doesn't want to leave my side. I worry about my son's physical and mental health from the environment that we're in all the time.
It's been about 25 years that I've worked in these communities. Trauma often remains invisible or unsayable, but we know from science that it's highly prevalent.
Listen back here. Can you breathe big? Good. I see every day in clinic kids coming in for asthma, obesity, mental health, behavioral issues. And traditionally, we've treated those symptoms. We've refilled the medicines. What we've learned is that the root cause of many of these diseases is actually what's happening early on in the home of the child, in the neighborhood, in the school. It's abuse, it's neglect, it's household dysfunction, it's experiencing violence and discrimination.
Research has shown that stressful or traumatic experiences in childhood can lead to activation of a prolonged stress response. The higher your adverse childhood experiences, the worse your health outcomes. This affects the way our brains function, it affects the way our immune system functions, it even affects the way our DNA is read and transcribed. For a person who has 4 or more adverse childhood experiences, we are talking about double the risk of heart disease, 2.5 times the risk of stroke, double the risk for cancer, 11 times the risk of Alzheimer's.
Thank you for listening to that, even though it was hard. And basically, here was the problem statement. We had Dr. Edward Mochtinger, Dr. Nadine Burke-Harris. They were treating very vulnerable women who had been abused, who had HIV, and they were bringing their families with them into the visits. And they were coming every time, and they were like, we're not helping these families. They're under duress. What can we do? And they felt like they had an intractable problem. They had an idea. And they did submit funds for health equity. We didn't call it Health Equity Innovation Fund in 2016, but for a corporate giving, and they got $2 million, and since then they've had 25 from us, but others from others. And what's happened is Dr. Edward Mochtinger said, you know, I'm a white Jewish male. How am I going to be able to connect to my Black women patients who've been abused by men? And he partnered with Rhodessa Jones, who is an activist and an actress in Oakland, and she helped these women act out their pain on stage. And they noticed the kids were under stress and duress, and they developed the adverse child experiences scoring. And they were able to take that, and they also created some unconscious bias training from the door staff all the way, empathy training, all the way to the physicians. And they took this and noticed when they started giving holistic care to the families, people were getting better. They took it to Sacramento, and they got Medicare to reimburse for the wellness program. It took a while. It took like 4 or 5 years, but it happened. And they thought differently, like, you know, I'm not going to be able to help these women. How can I go outside my walls and do something differently? So it gives me hope, because you can change policy, you can have access changes. And, you know, by the way, our Health Equity Innovation Funds are open right now. You have a workshop in an hour, so I'm hoping you come up with big, bold ideas. And I'm going to go a little fast in the last one. For the last few, sorry, I have a few more slides. We realized that, you know, if you can't afford food on the table, if you don't have transportation, you're not making it to the doctor's office. And we believe strongly in advancing race justice. So we did, the Giving Group created a community health justice fund where they're giving $6 million over 3 years for things like grant making. So they're teaching communities in Philadelphia, local communities, how to do grants to bring in. It's like kind of, you know, teaching you to cook, right? Not just bringing the food to the table. Food harvest networks, expanding them. So trying to go a bit further. And then this Rise to Health Coalition is actually multiple sponsors are involved, as you can see, but how are we training individual practitioners and healthcare organizations to lean into unconscious bias and think about how they're reaching every single patient? And then I want to bust a myth. Sometimes you'll hear, and my day job is inclusive research, how are patients in the studies should mirror the patients who have the disease. And we're largely not reaching our Black and Latino patients. By 2044, we'll be a minority majority nation. We have 19% Latino patients in the US. We're actually many more in California, and about 13% for our Black patients. And historically, across industry, we've done a really poor job of reaching our patients. So I want to bust the myth that it's slower to enroll patients of color. It's not. Every single one of these studies beat their timelines, and I'm talking about stretch goals. So Impacta, during the peak of COVID, New Jersey hospitals, you know how bad it was in New York during COVID. They felt we had a drug called Actemra that would keep their COVID patients with pneumonia off the ventilator. And they said, please give us this drug for our study. We ran a study. We co-created the entry criteria with the sites to make sure their patients who were in the bed made it into the study. We enrolled in less than a month, 389 participants. 84% were minorities, 15% were Native American Indigenous communities. It was incredible. Chimes MS during COVID as well took lessons learned from them and decided to dedicate a trial to enroll only Black and Latino patients because they felt that MS was more severe in these patient populations. Learned a lot, brought in 10 weeks ahead of schedule. Elevatum, diabetic macular edema, increased scope for Black, Latino, and Native American Indigenous, enrolled a month ahead. And all from learning from each other and also making mistakes, but learning how to be better. And Katori is, we're trying to understand better decentralized trials. And also our Native American Indigenous communities don't trust Western medicine. So learning from them what's important to them, so surveys, and it's a completely, there's some brick and mortar sites that aren't enrolling well, but the decentralized CRO, we've enrolled quite well. So learning differently, partnering with sites. We have 6 oncology, and City of Hope is one of them, 6 in oncology and 3 in ophthalmology, who are better than anybody else, any of their peers in the same studies. They are enrolling their communities. How can we take their best practices and share them with others and capitalize and co-create? I'm going to show you a few co-creations. I'm not going to run the video because I don't think we have time, but they told us 3 things when we first started partnering with the first 4 sites. Patients are clinical trials. So how are we improving inclusion in clinical trials? Patients don't want a placebo and they don't want to be treated like a guinea pig. We need to have representation in our videos and talk in layman terms about how patients are taken care of in clinical trials. And my hope is if you did one thing from this talk, just one, I know there's educators in the room, the first video you can't even see the picture of, it's won some awards, it was co-created with sites who are working their communities. Walk through it, see if you can have a table conversation with your family about it. Because I have seen tumors melt on scans in phase 1 trials. I just want people to have the option. I want them to know what's available to them. They can say no. They can get in, they can take off, but they need to know what's available to them. Some of our sites are putting the videos up, again, systemic bias, right? Here's the clinic visit, you can sign up here. Oh, by the way, have you heard about clinical trials? Go here. So take a look at the videos. They were co-created with our sites. We're doing more. We're doing ophthalmology. I'm almost done. I think we'll have time for questions. So I want to talk just briefly about what we're doing in studies. So Olivia talked earlier today. Our USMA colleagues are fantastic at pushing barriers, and they are starting to collect social drivers of health in their breast cancer trials. And what that allows us to do is not only understand who we're missing, and this is like socioeconomic status, income level, education, transportation, I'm blanking, but about 6 different measures. Not only are they able to tell who are we not accessing, they're starting to do analysis to understand what population differences are. Like folks with lower socioeconomic status are having higher pain measures. Perhaps they're not getting enough support, perhaps they need more help, but there are other things they're analyzing as well. So our hope is to get this optional social drivers of health embedded in our clinical research studies. And then another example is SOGI that I talked about, our LGBTQ populations. I remember at the peak of COVID, we got a letter from 13 congressmen, and they said, make sure please that you are reaching patients of color, women, and your LGBTQ minority, marginalized minority populations in your COVID trials. Please, make sure you're doing this. And we're like, yeah, we need to do a lot better at reaching our patients of color. When was the last time we looked at gender equity? Can make us double check that. And then we don't even measure sexual orientation. We have no clue. Did you know people my daughter's age, she's 23, 1 out of 7 individuals in her generation Z identifies LGBTQ. And I just encourage, I work with a lot of people that are smarter than me. They're like, collecting optional self-reported SOGI is like putting a flag in your waiting room. It's safe for me to come out. They don't have to, it's optional. They can decline, the site can decline, the IRB can decline, the country can decline, but we don't even have SEER data or census data for LGBTQ. We can't even measure the disparities in this group. Most of the data is around HIV studies. So SOGI collection is very important. Our Genentech Patient Foundation has been collecting since February 2022, and we've started pilots in our trials. And I just saw CDISC, our CR Standards group, is coming out with recommendations, so it's coming. I think clinics are collecting the information. It's just industry's a bit behind. So I'll wrap it with key takeaways, but I think my real message is you are clearly leaders in the room. You know your patients like no one else. You know what the barriers are in your own institutions and outside. And I just think you can dream and go bold, be big. It was go big, right? Go big. That's going to be my takeaway. Like dream big, because these things that seem so intractable that yes, will take time together, I think you can come up with some great solutions. And yeah, I think I said all that. But I want to leave you with a quote. Love this woman, first Black woman in space, Mae Jemison. I used to work for NASA, so I still want to and I've got people in the room I bet want to go to space. The future never just happened, it was created. And barriers, no barriers, right? Go as high as you can fly. Thank you.
We do have time for one question, and I see the first person I see. Thank you.
Thank you. Hi, my name is Tia Delaney Stewart, and I'll share some background just because I think it's important. I'm a registered nurse, and I've worked in this community of LA for more decades than I like to say. I volunteer for the National Action Network, the NAACP. I chair their healthcare committees, and I'm also an LA County Commissioner for Hospital and Healthcare Delivery Systems for District 2. And I share that because I want you to understand the lens for my conversation. I think you touched on so much when you talked about providers having bias in racism and addressing that in your Seek Color program. So I want to take 30 seconds to tell you about a Black man who in 2018 I met and found out after about 6 to 8 months of knowing him that he had a cancer. In 2019, got to know him a little bit better, began learning about his cancer journey. And by 2020, when COVID hit, became really involved in his cancer journey and realized that there was so much he didn't know because he was believing in our healthcare system. He was a smart, articulate, intelligent Black man with great insurance. So he didn't fall in any of those other socioeconomic factors. He had a high level of education, graduated from Howard University. So he was doing all the right things. And it wasn't until I got involved that I realized that he was really a number in the system and not a person. And as he went through his cancer journey, I found out a couple of things. One, until I got involved as a nurse and let all of his clinical team know that I was a nurse, he had never heard the word sarcoma, but he had a sarcoma. Two, that he needed a particular surgery that they told him he didn't need, he shouldn't have, but he had it, and it extended his life. Three, that there was palliative-related radiation available to him. No one talked about it, but he had lower back pain from the tumors pressing on his spine. He did it for 14 days, the pain went away, and he no longer needed to take the methadone. Four, that there were clinical trials available to him. No one talked to him about these things, but he was eligible for not one, but 2 clinical trials, and it was the second one that extended his life a little bit more. 5, that he was entitled to a full medical chart review via City of Hope. He didn't know it existed, but I did, and it happened, and they found out some other things that was important to his process. 6, when he couldn't eat anymore because the tumor was blocking his stomach, they told him there was nothing else he can do, and I said, well, what about TPN? No one talked about it, I did, and he was on TPN, and it extended his life another 9 months. And then 7, I think I'm on 7, when he was discharged home, the doctors had not done a walking O2 sats on him, and when he got home, his O2 sats were 86% resting because he needed oxygen in the home. But I did know that because I had an O2 sat at the home, and I did that. This man's name was Jakeem Makayu Stewart. In 2021, I became his fiance because we got engaged. In 2022, I became his wife because we got married in October of 2022. And in 2023, I became his widow because 61 days ago, he passed away. And I know for a fact that I helped to prolong his life. But what saddens me and his 2 children and my 2 children and all of his family is that I needed to come in his life years ago in order for him to have quality, equitable care. Yeah. And we might not be sitting here having this conversation about this Black man. Yeah. He was a number, he wasn't a person. And he didn't become a person until he had my voice, the voice who had to have all this knowledge and energy to use and research to do to make him valuable in our system. So we have to do more than talk about community partnerships. We have to talk about clinicians and physicians seeing us as human beings in our lives having value. We are not numbers in a system. We are worth more than 15 minutes. And until we do that, it doesn't matter how much engagement we do in the community and address social determinants of health, because it's the doctors and clinicians that make the final decisions, that push the buttons, that order the services, that make the differences. And so I thank you for having this equity forum. I thank you for bringing us all together. But again, until we see each other as human beings and value each other's lives, we'll be having this conversation 20 years from now.
Yeah, thank you so much for telling us your story. I'm so sorry for your loss. You're a great example of an amazing navigator. And that maybe that's a focus for the next workshop. But we heard a lot about navigators, being able to navigate a very complicated system when things are changing. There's something like 20,000 oncology trials going on worldwide. How can anybody keep up? But yeah, thank you for telling your story. I'm so sorry. If we had hundreds and thousands of you, maybe that's it. You can create an ambassador program. But I'll stop there. But thank you so much for telling your story.
Thank you. Again, thank you for sharing your story and for being with us today. One of the things we want to do, and I think this really brings the point home, is that we don't want to leave here today without actions. And I think, you sort of started us off on that conversation about how we can be more human and view all of us within the healthcare system. Our providers, our nurses, our researchers, our navigators, we all can benefit from being more human and seeing the humanity in all of us. So we're going to take a break. And then when we come back from the break, we want to convene ourselves into sort of coming up with action plans. And I think as part of that, being bold and being brave. And we might not think about, being human as part of being bold and being brave, but I think that's something we need to think about in our conversations. So I'll thank all of you for staying with us till this point in the day, and thank you again for sharing your story. I think it's the right tone and tenor for us to go into our next segment of our work together, because we don't want to come back next year and have the same conversation. We want to have some bold, actionable strategies that we can do to move the needle for all of us to be human. All right, thank you. Good afternoon, everyone. Thank you so much. At this point, we had planned to have a working afternoon session where we work in tables to develop action plans, strategies that we could really move forward in terms of addressing all of the issues that we've discussed today. But first, I just want to thank everyone for your contribution and participation, and for joining in this conversation this afternoon. We're going to change a little bit because we realize we've been here in this room for a long period. It's been a great discussion, but we've already heard a lot of, I think, key messages and strategies that we want to build upon. So we decided to flip the script a little bit and just really have an open, instead of like having everyone work in tables, we're going to work as a large group because we've spent a lot of productive time today and we just want to keep our momentum going. So with that, again, we're going to keep our sort of think tank approach to the workshop, which is really to identify ways that we can continue to work together to enhance our cross-center and cross-sector collaboration. And I think really just to put a point and bring back our discussion from the last session, to help us to integrate humanity within the context of cancer care, along the cancer care continuum. So a couple of things just to kind of sort of guide our thinking for this discussion. And we have some note takers around the room, and rather than sort of work in tables, what we'd like to ask you to do is sort of think about and respond to a couple of questions for our discussion today. So the first one is, based on what you've heard today, what groups or community needs to be increased, needs greater attention to reduce cancer disparities? So we have people with microphones who are able to come around. You can look, I'm gonna read, you all are reading quicker than me. I see some people like reading all the questions. So please just take a moment to think about these issues. What are ways that we can improve outreach and collaboration with communities and individuals in areas beyond the immediate neighborhood of our local cancer centers? If you think about being bold, what would the future of collaboration with community engaged research look like? And then think about being bold again. What does the future collaboration across centers and health sectors look like? And maybe we might start with this one. What's our biggest problem to solve in building collaborative networks or partnerships? And if you've thought about something during the course of the day that is really not reflected in the questions here, please, this is the time to raise it as what we need to be doing next to kind of build our collaborations. And I see Raymond has taken the microphone, so we're going to start with you, one of our PhD students in population and public health sciences. Raymond.
Thanks a lot. I guess I was going to answer the initial question or just give my thoughts on the initial one. One of the things that stuck out to me was the SOGI, sexual orientation and gender identity. The fact that that's not really collected really does, I can see how that really limits a lot of the work we're able to do with respect to disparities. So that was just one of the big things that I feel like with most of our studies as we're initiating them, that we can all try and start to include in that information, as well as on the hospital level in like the ERM type data.
Okay, thank you. So expand how we understand sort of a person's lived experiences, not just where they live, but how they live, and sort of having an expanded way of asking about those and understanding that within the context of cancer care. Okay, great, thank you.
Because I think we could have amazing partnerships with the community, but unless there's change at the system level, we're still going to run into the same issues, to her point. And so I think, I don't know if it was you or somebody I was just chatting with, like having payers in the room to be part of this conversation would be important. So how do we bring them into this work? Because it has to be upstream as well as downstream in order for it to work. And we see at least the needle move in the right direction.
So maybe a point about the future collaboration is that one sector that's missing from our conversation is the healthcare payers. Jennifer, do you want to speak on that a little bit? I know you've been leading our efforts here.
Yeah, I think, this is an issue that some of our FQHC partners have brought up, but some of what we've learned along the way as well. Just like all other partners, I think it also requires some relationship building. We'll invite them to come to the table, but it's also a little bit of a ongoing relationship that I think will also require some cultivation. And we're learning to do that along the way as well with some smaller projects and smaller sort of questions to each other. And I think perhaps some of where we can get to with the cross-center collaboration is how do we do that with multiple payers in LA and then bring them all to the table when they're ready with bi-directional sort of interests.
Okay.
Right.
All right. Megan.
Thanks. We heard a lot about navigation and hard to navigate the healthcare system, navigate what options there are. And with this opportunity with Medicare and community health workers, I think there's a lot of opportunity there. Like how are we really digging into community health workers, communication, health literacy with the public, but also navigation through the healthcare system and that connection to that handoff to different specialists helping somebody with serious illness. There's something there, and I think a lot of people are doing, navigation seems to be kind of a key piece that could help patients.
One thing that really struck out to me just in the conversation, and I'm not sure where it came up in our discussion, but is, we're all representing, we're here at USC, but City of Hope is our partner. UCLA is here. Cedars was here earlier today. We have many folks from industry. So my question is, what are some of the ways in which we need to think about partnerships, between our cancer centers? Any thoughts about that? Yes.
I think one thing we see, I mean, from an industry perspective, I think we're guilty of that as well. So Nina from Genentech, is that in order to build the collaborative networks and partnerships, these barriers that are from a legal and intellectual property perspective, and who owns what data, and who owns what approach or algorithm, or so I think, how do we create an open space? All of this information should be public, where if you're going down a path where things didn't work out or there were some failures, can we openly talk about those and publish the failures? We don't have to necessarily only publish successes, and be able to lift all boats. And sometimes I think our legal folks need to be in the room too, so that they can understand what are some barriers we've created for ourselves in order that prohibit us to partner so much more collaboratively and collectively.
Okay.
So,
Loretta?
Great question. And again, thank you so much for your leadership today. I think I see things very simply. I think just logistics is that we get into a room like this, and maybe we have like a representative or two from each institution, and we just declare that we're going to meet monthly, and that we're going to brainstorm and come up with like the top 2 or 3 issues that we collectively experience and that we see our patients suffer from, and that we decide, hey, we're going to have within 3 months of meeting action plan, strategy, and tactics around solving that issue. I think one of the things I've noticed about when we have a goal and have an intention, really we are individually unstoppable. And so when we come together, there's just no, I can't imagine what that will look like. So for me, I think the main barrier, I agree with you that there's a real need to sort of think about and talk to leadership about how we get over the competition thing. I think that's the thing. But more importantly is the time, and just giving something priority and deciding that this will fit within the bandwidth, that we've decided this is that important, that we will come together so that we can tackle whatever that particular issue is, and we come together and decide that. So that's how I would see it.
Thanks. I think this whole competition thing is not a real issue, to be honest, or at least not from where I sit or where John sits. I mean, I think the issue is coming up with, as you said, coming up with a strategy and a plan. And is John still here, or is he coming back? Okay, so we'll have something to share a little later. I didn't want to do it without him here, but we are all on board. We've got lots of collaborations with UCLA. So and Mike Teitel is a good friend as well. So if you're talking about the Cancer Center director leaders, we're all in. And I think I can speak for my colleagues and say that. So let's focus on what work we need to get done. I just mentioned those 3 institutions. So.
We caught that.
But one thing that you said, Loretta, really resonated with me, which is, trying to understand what are the commonalities in the issues that patients are facing, so that might sort of provide a way for us to think about the actions and tactics that we would move forward. So, we have a lot of experts in organization and keeping us organized. So, we'll look forward to that leadership. Other thoughts about anything that's on the, yes, Katrina.
Good afternoon. I'm Christina Martel, American Cancer Society, and I think for me, what is most important is to hear from the people. And I think that in the commissioner's story, the RN that spoke earlier, the Latina, I think we need to hear more from them. And if we can bring them together and the group of this group here so that we can listen rather than take action before we listen, if that makes sense.
It does.
People first.
And I think there was a comment, right?
Thank you. Hello, everyone. This is Rosa Navas, also with the American Cancer Society. Prior to coming into this organization, I was in health systems, specifically with the all-around well-being and also just health assessments. And one of the things that we did post-pandemic is what the leaders and what we thought was what the community needed was completely upside down post-pandemic. And I do feel like a conversation, to Christina's point, in the cancer space from patients themselves, from survivors, and from caregivers, almost like a focus group assessment in general, in the different communities that these cancer center partnerships are in, can really give us a good opportunity to listen and then take those learnings back into a room like this with representatives, key representatives from that space, and have some tangible items that maybe we could do a pilot and then see how we could scale it to everyone.
Thank you. And Ms. Tia.
I think what everyone said was great. I think I could only add that we need more people in our community that represent the community. And so making sure that we have researchers and clinicians and funding for researchers and clinicians as they're growing and developing in our community that represent our community. Because, you know, it excited me to sit at this table today with these young folks that were all doing work in research and they look like the community that they're working in. So I think that's also important for that outreach, not just to have them, but making sure that we're creating pathways, that there's funding and scholarships and opportunities for them to excel and grow, because they are our future. And if we really want to make an impact, we got to make sure we're making an impact in their lives as well, so that they can begin to make an impact in our clinical industry.
Hi, so I just wanted to mention two things. One is to consider adding to some of the populations, people with disabilities or able people in other ways, because I think that's one group that we tend not to focus too much on, and cancer causes many disabilities as well. And so we may want to consider that. And the other thing is to really think, you know, like not just outside the box, let's blow up the box. And, you know, bring in non-traditional partners into this. So some of the work that we have done and our team has done is to work with local artists in the community. We've worked with 11 artists in the community to deliver specific messaging, imagery, and things that are really in tune with the community that really drive the messaging home. So I think that also thinking about going beyond the traditional partners we work with and coming up with these unique, you know, sort of combinations of people that represent the entire community in different ways might be one additional thing to think about.
Okay, great. Sure.
I love, you have best practices that are different in reaching your patients and pilots. So I know City of Hope has this amazing program, and we interviewed a patient, Joseph, who said, I know my driver who comes to bring me for cancer treatments. Each of you have something you're doing uniquely that's really good for patients. I love your idea of monthly meeting, even just sharing best practices and like what can we do across. So I just wanted to add that. And I'm with you on bringing the community to steering committees. Sorry, I have to leave, but bringing in diversity to steering committees, to your patient councils. I think there can be a goal for that. Let's look, do we have diversity on our steering committee, our scientific steering committee, on our board? So I think you can look at goals for diversifying. Maybe you already do.
Okay, thank you. So one thing that this has been a great discussion, and I think, Narissa?
I'll just add a quick one for increasing the cross-cancer center collaborations. We've been having sidebar conversations here too. But we're all friends, we're all colleagues across institutions. We have similar interests, and even as a concrete example, how we can leverage infrastructure and common funding. We all applied for the HRSA funding announcement to strengthen partnerships between NCI comprehensive cancer centers and federally qualified health centers. We each independently applied and each have, received funding for this. So when there's commonality like that, I think that's a really good place to start.
Wonderful. Raymond, last word, and then I'm gonna.
I want to add one thing in terms of like something actionable. I just want to add one thing in terms of something that might be more actionable, particularly with the higher end players in the room, is actually implementing. I know some institutions are starting to do that, like Cedars-Sinai is implementing use of the Z-scores and implementing that across hospitals. I don't know if that's something that's changed in the past 2 years, but it sounded like social determinant of health for like the ICD codes, but there's a Z code for that, for like 12 social determinants of health. And so it's not mandated to fill that out currently, or at least as of 2 years ago. I don't know if it's changed in the past 2 years, but I know that that was a big thing at that point in time. And if the institutions can come up together, perhaps at these monthly meetings, to have a systematized way to implement mandating that being used, we can at least have more data on that to explore some of these health disparities. But yeah, I just wanted to, in terms of something that might actually be actionable.
Yeah, thank you. So one thing I think, we have a lot of great ideas. It's been a fantastic discussion. We will commit to organizing a monthly, some follow-up meetings to further this conversation. Because, we've sort of continued our larger gathering with the support of Genentech. We're excited to continue keeping this momentum, and we will do that. So we will do that. So I'm going to invite John and Karen up to give us some closing comments. John Carpton. Karen Lerman.
So I think you guys all figured out John and I have been good friends for a while, and I mentioned the comment that we all want to work together. So the competition, there may be some places where that's true, but not among our institutions or UCLA. And I know if you guys were not in the throes of your core grant, Mike would be here. So, but what John and I wanted to offer, to demonstrate, to walk the walk, is that each of our institutions contribute $500,000 to a collaborative project that's based on the work coming out of this meeting. And I'll let you have the last word.
And industry's gonna match that, right?
That's right.
No, amazing day, a lot of knowledge exchange, and just looking forward to advancing these initiatives. So thanks, everyone.
So thank you, everyone, for such a productive, engaging conversation. We are excited to partner with all of you in this room and beyond. Thank you again to Genentech for the support. Thank you to Karen and John and Norris and City of Hope. Thank you to our speakers, our panel members. Thank you to my team for a wonderful organization. We're just getting started. Thank you, everyone.